بسم الله الرحمن الرحيم. Solitary pulmonary nodule imaging. Solitary pulmonary nodules defined as vocal round or oval areas of increased opacity in the lung that measure less than 3 cm in diameter. If larger than 3 cm, it is defined as masses. We have home 5 masses in this lecture. First message is the lesion solitary. Is the lesion a nodule? Is it intrapulmonary? Is the lesion particular benign type, indeterminate, malignant? Solitary pulmonary nodule algorithm. What are the criteria for calling a lesion as solitary pulmonary nodule? Single lesion, intrapulmonary, round or oval, not bilinear or angular, less than 3 centimeters in diameter, lung completely surrounded by lung parenchyma, lung completely surrounding by functional tissue without associated pneumonia, atelectasis, or lymphadenopathy. Solitary pulmonary nodule divided into intrapulmonary or extrapulmonary. Extrapulmonary divided into extrapleural, pleural. Extrapleural divided into thoracic cage nodule mediastinal origin. To differentiate between pulmonary and extrapulmonary, we found lung mass abates mediastinal pleural surface, creates acute angle with the lung. Here mediastinal or pleural mass extrapulmonary with seat under surface of the mediastinum and pleura, creating obtuse angles with lung. This is one of point of differentiation. Acute angle in pulmonary, obtuse angle in extrapulmonary mass nodule. Another differentiation, pulmonary lesions. In axial contrast enhanced CT, we show peripheral edge cell carcinoma of the lung, mass centered within the lung tissue, makes acute angle with the chest wall. This criteria of pulmonary lesion. Extrapulmonary lesion, in this BA radiograph, we found solitary fibrous trauma of the pleura, incomplete circle border sign, yellow circle, is observed, only portion of margin of the mass depicted, incomplete circle sign, incomplete border sign, and obtuse angle with the chest wall. That's mean is extrapulmonary lesion. Solitary pulmonary nodule either neoplastic in 20%, malignant, non-neoplastic granuloma 80%, non-neoplastic either solid or cystic. Neoplastic solitary pulmonary nodule either benign, malignant, solid or subsolid. Benign like solitary fibrous tumor, hamartoma, bronchial adenoma, intrapulmonary lymphadenopathy, lipoid pneumonia. Malignant primary lung malignancies like bronchial carcinoma, carcinoid metastasis. Neoplastic solitary pulmonary nodule may be solid or cystic, may be solid or subsolid or semi-solid, not cystic, solid or subsolid and semi-solid. Subsolid or semi-solid, it's purely ground glass attenuation, partly solid, mixed solid and ground glass attenuation. Solitary pulmonary nodule non-neoplastic, infective like round pneumonia, abscess, infective granuloma, tuberculoma, histoplasmosis, pseudomycosis, pneumocystis carini, fungal infection like aspergilloma, actinomycosis, mystoma, parasitic like hydatid cyst, septic embolus, congenital sequestration, bronchogenic cyst, bronchial atresia, mucoid impaction, vascular like EVM infarction, iatrogenic pulmonary hematoma, autoimmune fasciculitis like vaginal granulomatosis, rheumatoid nodule sarcoidosis, mimics pleural mesothelioma, liquelated interpleural effusion, benign pleural lipoma, phantom tumor in congestive heart failure. This pleural origin of mimics rib, one of solitary pulmonary nodule, mimics healing fracture, rib, osteoma, thoracic wall hematoma, nipple shadow. Congenital solitary pulmonary nodule, first type intrapulmonary sequestration. 2/3 of this lesion in the left lower lobe, 1/3 in the right lower lobe contiguous with to the diaphragm, will define around or over this character intralobar sequestration, characterized by demonstration of the feeding systemic artery from the aorta and the draining pulmonary vein intrapulmonary type or bronchial vein extralobar type in aortography, CT, MR, angiography. Pulmonary sequestrations, this is pulmonary sequestration cases. Bronchogenic cyst, round or oval, well defined, mostly middle mediastinum, non-enhancing cystic in CT. Bronchogenic cyst in conventional demonstrates subcarinal mass. Bronchogenic cyst in CT, subcarinal mass, middle mediastinum with fluid density non-enhanced. Bronchogenic cysts presents high signal intensity in T1 and T2. In T1, high signal intensity due to protein content of the cyst, fluid retained secretion. In D2, high signal intensity due to fluid content. This bronchogenic cyst. CT demonstrates fluid density, non-enhanced lesion. Bronchocele, it's one of congenital solitary pulmonary nodule. Bronchocele meaning mucoid impaction, characterized by branching of the ends of the nodule, gloved hand appearance due to the presence of bronchiole distended with secretion. Branching Y-shaped bronchocele in the posterior segment of the right upper lobe, more proximal irregular obstructing mass present. Bronchocele branching finger glove appearance, fluid containing, high signal in T2. Segmental bronchial atresia, right lower lobe show a nodular area of increased opacity in the lower lobe. Right lower lung show branching nodular area of increased attenuation in the right lower lobe, as well as pulmonary parenchyma with lower than expected attenuation. This is characteristic of segmental bronchial atresia. Granuloma or infection solitary pulmonary nodule, and the most common type differentiation of solitary pulmonary nodule. Pattern of calcification in solitary pulmonary nodule, benign or malignant calcification, benign like central calcification, diffuse solid homogeneous calcification, laminated crescentic calcification, popcorn-like hamartoma chondroid calcification. Malignant calcification, either diffuse, amorphous, eccentric. Malignant calcification characterized morphologically as present as in diffuse, amorphous, eccentric pattern. Tuberculoma with infective granuloma, this is with calcification pattern. Tuberculoma, infective granuloma, solid nodule present in the right upper lung zone with calcifications. Tuberculoma more common in the upper lobe and on the right side, well defined, 25% lobulated. Calcification frequent, 80% have satellite lesion. Cavitation uncommon, when present is small and eccentric, usually persists and unchanged for years. Occasionally it may be distinguishable from carcinoma. A lung post-primary TB recent sign, which characteristic finding for stoma as aspergilloma. Tuberculoma, 21 mm nodule with lobulated spiculated markings. Hydatid cyst, most common in the lower lobe, right side, well defined, solitary in 70%. Large may reach to 10 cm. Cystic lesion in the apical segment of lower lobe. Ruptured hydatid with what's called water lily sign. Pulmonary hydatid asymptomatic unless cysts become large enough to produce mechanical pressure on surrounding tissue or rupture. Histoplasma capsulatum, benign pattern of calcification in granuloma, central pulse-ine area of calcification that's highly suggestive of granulomatous infection. Histoplasma more frequent lower lobe, well defined, seldom larger than 3 cm. Central calcification common, produce target appearance. Cavitation rare, satellite region common. Solid calcification is feature of chronic granuloma. Histoplasmoma, smooth, well-marginated nodule, central area of calcification. Coccidiomycosis right lower lobe nodule, secondary to disease. Coccidiomycoma lyscomally associated with TB calcification. Primary pulmonary cryptococcosis present as a solitary pulmonary nodule. The solitary nitrocardiac pulmonary nodule. Granuloma left lung show soft tissue nodule, central calcification in the upper lobe, not the eccentric cavitation with the nodule. Calcified granuloma, solid calcification nodule. Solitary pulmonary nodule granuloma, calcified hilar node, calcification in solitary pulmonary nodule. Smoothly marginated subpleural nodule, the diffuse pattern of calcification consistent with granuloma. Organizing pneumonia may appear as well-defined nodule. Organizing pneumonia, nodule without speculation or obvious pleural indentation. Round pneumonia, poorly marginated nodule in the mid-lung. Pneumonia simulating carcinoma, 2 cm left upper nodule with speculated border, interpreted primary as bronchogenic carcinoma. Follow up later on show complete resolution of the nodule present of pneumonia simulating carcinoma. Lipoid pneumonia speculated mass in the left lower lobe, contain fat attenuation, indicate presence of lipid deposits. Exogenous lipoid pneumonia may appear as solid nodule, fungal infection, or cavitating nodule. Fungal nodule may be present as a solid nodule or cavitating. Fungus ball, aspergilloma with crescent sign, crescent of air between infected lung cavity and the fungus ball. Fungal pneumonia aspergillus, fungal pneumonia and the air bronchogram sign, right lower lobe lesions, air-filled bronchi, air bronchogram sign consistent with pneumonia. This is presentation of effective solitary pulmonary nodule, mystoma, invasive pulmonary aspergillosis, fungus ball, aspergilloma actinomycosis. This variety of infective fungal solitary pulmonary nodule. Feeding facial sign, septic pulmonary embolism. Feeding facial sign, facial directly leading to the nodule, seen in several nodules. Neoplastic benign nodule, neoplastic solitary pulmonary nodule. Hamartoma, 96% occur over 40 years. 90% intrapulmonary, usually within 2 cm from the pleura. 10% produce bronchial stenosis, usually less than 4 cm in diameter, well-defined and lobulated. Calcification in 30%, incidence increases with increase in size of the lesion. Calcification popcorn, Craigie or punctate. On CT lesion may show attenuation value of fat. Hamartoma, homogeneous, sharply marginated lesion with small focal area of calcification, and fat is typical feature of hamartoma. Central popcorn-like calcifications, pulmonary hamartoma variety. This is lobulated nodule, fat content, area of fat attenuation, diagnostic for hamartoma. Solitary fibrous tumor, benign solitary pulmonary nodule, non-specific well-described nodule. Pulmonary cyst, this is emphysematous with well-marginated nodule in the left lower lobe, homogeneous left lower lobe nodule. This is solitary pulmonary nodule, large well circumscribed mass in the periphery of the right upper lobe, neurolimb arise adjacent to the rib. Peripheral pulmonary lipoma, well defined, round shape, fat density nodule in the lateral segment of the right middle lobe, neoplastic malignant solitary pulmonary nodule. Bronchial carcinoma, 15 to 20% of all solitary nodules at 40 years, appearance suggesting malignancy are recent rapid crossing of fissure, ill-defined speculated margins, linear strand, bronchus sign, eccentric amorphous calcification. Solid nodule is amorphous calcification pattern in the right upper lobe in the bronchial carcinoma. Stippled or eccentric pattern of calcification in bronchial carcinoma. Bronchial carcinoma with bronchus sign, bronchus leading directly to the lesion. Bronchial carcinoma speculated corona radiata sign, speculated border of nodule. Bronchial carcinoma with linear strand connecting lesion to the pleural surface. Solitary pulmonary nodule in calcified carcinoid tumor. Marginated ovoid lobular pulmonary nodule, solid, typical pulmonary carcinoid lobulated nodule with scattered punctate calcification. Doubling time in solitary pulmonary nodule, less than 20 days in infectious causes, more than 450 days in old granulomatous solitary pulmonary nodule. Malignant doubling time between 20 and 400, mean 160 day. Small cell carcinoma mean 86 day. Large cell carcinoma mean 68 day. Metastasis may present as solitary pulmonary nodule in 3 to 5% of asymptomatic nodule, 25% pulmonary metastasis solitary, most likely primary breast sarcoma, seminoma, renal cell carcinoma, predilection for the lung periphery, calcification rare but may occur in osteosarcoma, chondrosarcoma, mucus-secreting neoplasm of the GIT. This is solitary metastasis present in the 1 cm diameter coin-shaped smooth peripheral nodule in primary bladder carcinoma. This is calcified metastasis from osteosarcoma, calcified metastasis from adenocarcinoma, metastatic osteosarcoma, small high attenuation nodule, solitary pulmonary nodule metastasis, small end bronchial metastasis from renal cell carcinoma, solitary 10 mm nodule pulmonary metastasis from renal cell carcinoma, not seen in chest X-ray, metastatic deposit of colonic carcinoma, left lower lobe metastasis pancreatic cancer, reverse halo or atoll sign. This is what we mean after 1 month of radiofrequency ablation with treated metastasis show high mixed attenuation surrounded by ground glass opacity. I will circumscribe the rim of consolidations present. This is reverse halo sign. Reverse halo sign differential diagnosis, atoll sign, paracoccidiomycosis, tuberculosis, lymphoid granulomatosis, vagrant granulomatosis, sarcoidosis, and tumor after radiofrequency ablation. Intrapulmonary lymph node present as solitary pulmonary nodule. Role of PET CT in solitary pulmonary nodule. This diagram demonstrates functions or how PET working. We use fluorodeoxyglucose 18 to enter the cell. Intense FD uptake in the nodule. This is characteristics of solitary malignant pulmonary nodule bronchogenic carcinoma with intense uptake at the left right lung base, demonstrates speculated right lower nodule is a peripheral cavity corresponding 18 FDG bit used, demonstrate intense uptake in the nodule, keeping with bronchogenic carcinoma. Mediastinal or nodal distant metastasis, intense FDG uptake in the nodule. Differentiated adenocarcinoma cases, 2.8 cm nodule right middle lobe. We show uptake of nuclear material, intense uptake of radiopharmaceutical material in the region of the nodule in the chest. technetium 99 with SPECT non-small cell lung cancer demonstrates in the right lower lobe increased FDG uptake in the right lower lobe mass. PET false, either false positive in infection and inflammation or false negative in small size nodule, ground glass lesion, indolent cancer, bronchoalveolar carcinoid. Bayesian analysis is another type of analysis used to classify nodule either benign, malignant, indeterminate. This is website. We use the number of malignant nodule with a certain feature divided over number of benign nodule with the same features, with odds related to size, shape, age, calcification, and we do equation for probability of cancer by using these odds to be differentiated into benign, malignant, indeterminate. Subsolid nodules divided into priorly ground glass attenuation or partly solid. Purely ground glass attenuation, which is higher than that of normal lung parenchyma and lower than that of soft tissue, such as pulmonary vessels, or partly solid, mixed solid, and ground glass attenuation. Either solid, subsolid, semi-solid nodule, solitary pulmonary nodule, divided into persistent or non-persistent, so divided into purely ground glass attenuation or partly solid. Purely ground glass higher than normal lung parenchyma and lower than the soft tissue such as pulmonary vessels by mean attenuation present between lung parenchyma and soft tissue attenuation, or partly solid, mixed solid, and ground glass, or divided subsolid, semi-solid, solitary pulmonary nodule divided into persistent and non-persistent. Persistent subsolid solitary pulmonary nodule divided into malignant, benign, malignant lung adenocarcinoma including pre-invasive, atypical adenomatous hyperplasia, adenocarcinoma in situ, metastasis from melanoma, renal cell carcinoma, adenocarcinoma of the pancreas, breast and GIT, and lymphoproliferative disorder, benign like organizing pneumonia, vocal interstitial fibrosis, endometriosis. This is persistent subsolid solitary pulmonary nodule. This is long subsolid nodule demonstrating peripheral ground glass opacity with solid central component. This is atypical adenomatous hyperplasia (AH). Typically has pure ground glass attenuation and the measure less than 1 cm. This is adenocarcinoma in situ (AIS). Typical pure ground glass attenuation and the measure less than 3 cm. This is minimally invasive adenocarcinoma lesion, has predominantly lipidic pattern, lacks necrosis, do not invade lymphatics, blood vessel pleura, measure less than 3 cm, has an invasive component that's measured no more than 5 mm in any direction. This is lipidic predominant adenocarcinoma, LPA, in its non-mucinous form. Necrosis may be present, and the focus of invasion of lymphatic blood vessel greater than 5 mm. This is adenocarcinoma present as pure ground glass attenuation in the left lower lobe, subsolid solitary pulmonary nodule. Follow-up CT 3 years later show increased in size and attenuation. Volume doubling time of subsolid lung cancer, typically longer than that for lung cancer. This is GGAN resulting from infection, ground glass attenuation nodule, GGAN, ground glass in the left lower lobe, resolution ground glass opacity after 3 months. This is ground glass attenuation result from infectious or inflammatory cause, may regress or resolve in the interval time. This is mediastinal window setting for major solid component subsolid lesion. Lung window show ground glass attenuation component of the lesion. Percentage of solid to ground glass attenuation component. Greater solid component, more likely more invasive adenocarcinoma. This is subsolid nodule in the right lower lobe with predominantly ground glass attenuation. Follow CT up 1 year show nodule with increase in size and attenuation. This is PET CT show low FDG uptake in the nodule, which characterized or compatible with vocal organizing pneumonia, infectious subsolid solitary pulmonary nodule. For patient with a subsolid lesion, the initial 3 months follow-up at CT is to determine persistence. Because lesions that result from infectious or inflammatory cause may regress or resolve in the interval, this increased attenuation of subsolid nodule is increased risk of malignancy. This is subsolid nodule in the left upper lobe, and 1 year later, nodule increased attenuation and increased in size, compatible with adenocarcinoma. This is also nodule pure ground glass attenuation. The left upper lobe pulmonary vessel air bronchogram sign visible in the lesion. 3 months later, nodule with a new solid component. Vascular solitary pulmonary nodule. Arteriovenous malformation. Nodule surrounded by serpiginous vascular structure feeding artery and draining vein. Round bullated well marginated nodule in the lower lobe. Needles of malformation. Feeding artery and enlarged draining vein. This feeding artery and enlarged draining vein. Large bullated well marginated nodule lower lobe, EV malformation, hereditary hemorrhagic telangiectasia. This is pulmonary infarct typical wedge-shaped pleural based. Right lung show poorly marginated nodule peripherally in the lower lobe. This is pulmonary hematoma, well marginated nodule in the middle of the left lung. This is post-transplant invasive pulmonary aspergillosis, one of presentation of solitary pulmonary nodule. After post-transplant operation, like renal transplant, liver transplant, we found fungal infection, solitary pulmonary nodule in lung transplantation before after treatment resolved. This is other mimics of solitary pulmonary nodule. Around atelectasis, one mimics of solitary pulmonary nodule appear as peripherally located pleural based nodule with linear strands curving toward nodule from surrounding lung parenchyma. Round atelectasis, as was found, patient with cutaneous neurofibromatosis with static carcinoma metastasis. This is mimics of solitary pulmonary nodule. Which is mimics? Is cutaneous neurofibromatosis may be present in the X-ray as intrapulmonary solitary pulmonary nodule. In CT, it's present as cutaneous nodules. Multiple exostosis, rib lesions, fracture, multiple exostosis, osteoma. This is one mimics of solitary pulmonary nodules. We found osteosarcoma of bilateral fifth rib. Chest X-ray with patient secondary lymphoblastic leukemia. Multiple myeloma present a rib lesion, one of mimics of solitary pulmonary nodule. Osteophyte of the left first rib, poorly defined nodular area of increased opacity, overlying anterior aspect of the left first rib. Healed rib fracture. This is callus formation secondary to rib fracture, one mimics of solitary pulmonary nodule in X-ray. Bone island, vocal area of increased opacity, overlying right seventh rib, one of solitary pulmonary nodule mimics. Pseudonodule, smooth marginated nodular area of increased opacity projecting over lung. This is EC, electrocardiographic lead attachment pad. Pseudotumor of the lung, finishing tumor, which present congestive heart failure. In fissures, pleural pseudotumor, lenticular biconvex contour, interlobar effusion located along course of the interlobar fissure, one mimics of solitary pulmonary nodule. This is pull track from a gunshot, smoothly marginated sequoid nodule with eccentric lucency in the mid-lung, polyp fragment as we see. Fasciculitis, solitary pulmonary nodule causes. Rheumatoid nodule periphery of the lung, multiple rarely single. Wagner granulomatosis, one of differentiation of vasculitis solitary pulmonary nodule. Algorithmic approach of the solitary pulmonary nodule. Solitary pulmonary nodule imaging diagnostic criteria include site, size, shape, border, calcification, cavitation, change of size over time, or other finding in thorax, attenuation in CT, enhancement on CT, uptake on PET and SPECT. As regard the shape, either sharp, smooth edge, moderately sharp, smooth edge, mostly benign, moderately sharp, smooth edge, small irregular undulation or slight speculation tends to be malignant. Grossly irregular undulation with speculation mostly is malignant. As regard of density characteristic contained CT densitometry, benign pulmonary nodule frequently have a higher attenuation value in an enhanced CT than malignant nodule. As regard the attenuation MR signal classified according to the content. Solid nodule, soft tissue containing, mostly neoplastic, benign or malignant. Fat containing nodule in lipoma, hamartoma, lipoid pneumonia. Calcified containing in hamartoma, EVM, tuberculoma, ossified metastasis, calcified metastasis. In cyst, water containing in hydatid, bronchogenic cyst and encysted effusion. Subsolid or semi-solid solitary pulmonary nodule. This is according to the attenuation and the content divided into solid, fat containing, calcified containing, cyst, water containing, or subsolid or semi-solid solitary pulmonary nodule. Contrast enhancement dynamic study. Dynamic study 5-minute period, sensitivity 98%, specificity 73%. Nodular enhancement less than 15 ounce field suggests lesion benign. Enhancement greater than 20 ounce field more likely associated with malignancy. Carcinoid tumors examples before after administration of contrast material show a high enhancement, increased attenuation. This is characteristic of malignant nodule. Malignant nodule typically enhanced with increased attenuation more than 20, while benign increased attenuation less than 15 ounce field. As regard risk factor, classified patient risk factor, radiographic risk factor. Patient risk factor, advanced age, history of cigarette smoking, history of extrathoracic cancer, diagnosed almost 5 years before detection of solitary pulmonary nodule. Radiographic risk factor speculation, rigid age, once or more of malignant, nodule size correlate with a likelihood of malignancy in solitary pulmonary nodule, growth rate, doubling time. Border analysis, either well-defined carcinoid metastasis, solitary fibrous tumor organizing pneumonia, lipolated border, lipoid pneumonia, hamartoma, EVM hamartoma, speculated ill-defined border, bronchogenic carcinoma, or round atelectasis. As regard the calcification, either probably benign central solid popcorn calcification, solid central popcorn is typical of benign, hamartoma, carcinoid, histoplasmoma, solid central, hamartoma, popcorn calcification, granuloma solid, and sequestrations and granuloma as we see. Calcification probably malignant, amorphous, eccentric, speculated calcification. Cavitation. As regard the cavitation, bronchogenic cavitation. Cavitation either benign or malignant cavity according to the wall thickness and irregularity of the wall and solid content. Sequoid irregular bronchogenic carcinoma, abscess with fluid containing fluid levels and thin wall, actinomycosis, fungus ball, tuberculoma. Cavitation, invasive pulmonary aspergillosis, cryptococcosis, aspergilloma, mystoma, crescent sign. As regard change size compared to previous imaging study, growth rate, doubling time. No growth over 2 years, tuberculoma, histoplasmoma, hamartoma, EVM, decrease in size, hematoma, pneumonia, abscess, increase in size, bronchogenic carcinoma, and metastasis. As regard the site, tuberculoma present mostacoma right upper, histoplasmoma right lower mid-lung zone, hamartoma present in the right midgland zone mostly. Metastasis present بتاخد basal part because it's mostly part perfused with blood. Infection peripheral wedge-shaped pleural base. Hydatid right lower lobe. Sequestration left lower lobe most common site. Adenoma central parahilar. Bronchogenic cyst middle lobe to right. Middle mediastinum. Bronchogenic carcinoma present everywhere. As regards size, histoplasmoma solitary pulmonary nodule seldom larger than 3 cm, sequestration less than centimeter, adenoma less than 4 cm, tuberculoma 0.5 to 4 cm, hydatid cyst 1 to 15 cm, hematoma usually less than 4 cm, EVM less than 4 cm, metastasis variable from the very small to cannonball, bronchogenic carcinoma any size. Solitary pulmonary nodule detected in chest X-ray, what we do? If incidentally discovered on chest X-ray, no symptom, we try to look for previous chest X-ray. If we found no change in size or morphological feature for 2 years, stop, no further imaging study. If we found nodule not present in previous radiograph, nodule has increased in size, nodule has changed morphologically or previous chest X-ray not available, we go to an enhanced contrast enhanced CT. If we found solitary pulmonary nodule in chest X-ray and detected in chest X-ray with symptomatic patient, particularly hemoptysis, and the nodule not present in previous radiograph, on radiograph not available, nodule increased in size, nodule changed morphologically or previous chest X-ray not available, we go to an enhanced contrast enhanced CT. Then CT of pulmonary nodule. Look for calcification. We found central well-defined dense and lobulated popcorn calcification, or amorphous calcification, or no calcification with nodule. Central well-defined lobulated popcorn calcification, either asymptomatic or symptomatic, or patient has primary neoplasm. If asymptomatic patient, symptomatic hemoptysis, cough, or endocrine, or has primary neoplasm. Asymptomatic patient, benign nodule, no further imaging. Symptomatic hemoptysis, cough, or endocrine carcinoid with percutaneous CT guided needle biopsy. Has a primary neoplasm, calcified, ossified metastasis, osteosarcoma, mucus secreting tumor. We do CT guided needle biopsy. Solitary pulmonary nodule with no calcification with amorphous calcification. Imaging features suggestive of particular type of nodule or speculated outline old age smoker or hemoptysis with high probability of malignancy. No frank sign of benign malignant nodule, indeterminate nodule. Imaging features suggestive of particular type of nodule is found solitary pulmonary nodule with no calcification with amorphous calcification. Imaging features suggestive of benign type, we diagnose type of nodule, we don't need further evaluation. Ruptured hydatid cyst, water lily sign, bronchogenic cyst with characteristic site and signal high T1 and T2 fluid containing CT, fungus pool with crescent sign, intralobar sequestration with breathing vein and supply early arterial supply, IV malformation with its characteristic pattern of EV arterial venous supply, round at plexus characteristic side, solid, basal, peripheral, exogenous lipoid pneumonias, fat containing, acquired bronchoceous fungal glove sign. This is features which is suggestive of which type of benign pulmonary nodule. We don't need further evaluation. Is present in CT with no calcification. It is found solitary pulmonary nodule with no frank sign of benign or malignant lesion, indeterminate or speculated outline, old age smoker, hemoptysis, high probability of malignancy. Indeterminate nodule, we do perform FDG, PET or nuclear study or contrast enhanced CT according to availability of enhancement less than 15 on contrast CT or low uptake on PET or smooth nuclear SPECT. we do image follow-up with volumetric CT every 6 months. Of enhancement in CT more than 15 or high uptake of 18 FDG bit or SPECT nuclear technetium, protocol for high probable malignancy must be active. Solitary pulmonary nodule with speculated outline, old age, smoker, no or hemoptysis. It is a risk sign patient, smoker, hemoptysis, old age, speculated outline, radiographic risk factor, patient risk factor present with no calcification or amorphous calcification, high probability of malignancy. High probability of solitary pulmonary nodule, high probability of malignancy, we do BIT FDG or BIT CT for confirmation of diagnosis and assessment with spinal lymph node. If we found positive, we go to surgical protocol. Subsolid nodules, either ground glass appearance, algorithm of subsolid nodule, ground glass less than or equal 5 mm, ground glass more than 5 mm, partly solid nodule. This is less than 5, more than 5 mm, partly solid nodule is ground glass attenuation. Ground glass less than equal 5 mm, no follow-up required. Ground glass more than 5 mm, 3 months follow-up with C-section to assess the persistence, either resolve or persist. Partly solid nodules with ground glass attenuation, follow-up 3 months to assess the persistence, which either resolve or persistent. Either resolve or persistent nodules. If we resolve, no follow-up required. It's infection. Of persistent, we do what? If persistent, what we do? If soft tissue component more than 8 mm, consider BIT CT. Of soft tissue component less than 8 mm, low dose CT manually for minimum 3 months. Of soft tissue component less than 8 mm, low dose CT minimum 3 months manually. Assess for increase in size, increase attenuation, new or increased solid component. This is increased risk of malignancy. Then consider biopsy or surgical resection. Of persist, of soft tissue component more than 8 mm, consider BIT CT. If negative, case by case serial follow-up CT or obtain tissue biopsy or surgical resection. Of persist soft tissue component more than 8 mm, consider BIT CT. Of positive, consider biopsy or surgical resection. If soft tissue component more than 8 mm and negative, BIT CT, consider case by case serial follow-up. If positive, consider biopsy, surgical resection. Of persistence less than 8 mm soft tissue component, we do follow-up every 3 months for assess size, attenuation, solid component. If positive, consider biopsy or surgical resection. This is algorithm for subsolid solitary pulmonary nodule. Thank you.